Okay, welcome back, everybody. So this is the really, really fun part of the whole day. It's been a tremendous day. I'm totally overwhelmed by our speakers and how smart they are about everything, and all of you for being part of this very, very special first meeting. So, as you know, I'm a big James Bond fan, so we thought we'd start off with 2 James Bond trivia questions. We have the prizes, right? Okay. So here's the, we're going to load up the questions. So you have to submit your answer and your last name, and whoever gets it in first wins. The question is, what was the first James Bond novel? You can Google. Dr. No is not correct. Nope. Goldfinger? No. Goldfinger? No. Good guess, though, Peter, wherever you are. Okay. Jeez. Casino Royale wins. Phil Smith. Phil Smith. Where is Phil Smith? Is he here? Here you are. Okay. What year? I'm just kidding. 1953. Okay. So, okay. So we'll have more questions, but Dr. No was the first movie, not the first book. So many people don't know this, but Casino Royale was actually the very first book. As you know, it was later made into a movie. So, okay. Are we ready? Let's give a second pause before we start because you just did? Okay. The Aston Martin DB5 is the best known car in James Bond movies. In which movie was the car first introduced? Background music. Goldfinger is correct. Is it Todd? Where's Todd? Todd, you're here. That was fast. Okay, so here's the thing. Someone asked me, are we allowed to Google to find the answer? And since the theme of the meeting is about man-machine synergy, absolutely. So if you're fast and Googling, right, Jack? You should. Why shouldn't you win, right? So, okay. All right. Okay, so the wanted to give our panel an opportunity to respond to a couple of sort of interesting poll questions that we have put together. So we're going to put together the first poll question for all of you. So, given a choice, who or what would you have read your next MRI? A seasoned radiologist. B, a good machine learning algorithm. Come on, B. Doesn't look like B's going to make it, huh? Okay. Where's Kurt? Is Kurt here? Right here. Job security, huh? It's good to know. You should publish this, right? This is a couple hundred people. Do you have data, by the way, on how the public feels, never mind the doctors?
I don't think the public knows.
I'm giving the mic, yeah.
I think that radiologists are just beginning to learn about this machine learning through the media. I think the public is starting to learn about it, but not enough where they would really think carefully about this choice yet. I think they're still happy to have a...
While you're talking, B is making a comeback. So maybe, Kurt, we ought to just leave it there.
Wait, hey, excuse me, just a minute.
You're voting. Okay, and we'll come back to that because it's interesting. It's actually about a little less than 2 to 1. So it's pretty close. Okay. Well, can we just stop it there? We kind of get an idea. It's about 60-40. All right. Going to make the next one a little bit more interesting. What who or what would you like to devise a therapeutic strategy for a cancer diagnosis in yourself or a family member? A seasoned oncologist, IBM Watson, or any artificial intelligence inspired software? And both is choice C. A, B, or C. Rob?
Wow.
Very interesting. Very, very interesting. So, still have some trust in the seasoned oncologist, but much more trust for the two combined. So, all right. So we're going to use that as a start. I've invited Enrico, who flew in from Australia to be with us, to be a co-moderator, and Jack Poe from Google. So they're going to take it away. I'd like to end. Is the timer up? Let's put the timer up so that we can end up with the reception at 5:30. So we're going to end with one of my favorite questions, which is in a tweet format, i.e. no more than 15, 30 seconds, for everybody to say what was their biggest insight after the first day today from the speakers, all right? And then we'll also have an opportunity for all of you to text in your questions as well. So we're going to take it. I'm going to have the co-moderators take it from here. We see some of the questions that have come up. So any question from, we'll have the lights up in the house, please. You guys can take either one. Enrico, you want to take it first? Okay.
So, what I think, my take home?
Well, you can take any question and just moderate that side.
Okay, okay. Okay, we'll go see you guys.
You sound like statements. How about some questions?
Yeah.
We had a lot of questions before that weren't taken.
Okay, I like this one here. So are we in the middle of a hype bubble? We've seen a couple of AI peaks and winters before. Is this really different, or are we in 2 years' time going to be not mentioning that what we did in the war?
This time AI is coming to scale, and it deals with lots of data. All the previous bubbles were more conceptual and working with lower scale, and therefore it didn't come into real practice. Now AI is scaling up, and I think although much hype will be removed in a few years, still what will be left will have an impact.
You know, even though the previous cycles might have been bubbles, they did rise the tide a little bit as well. For anyone who's actually inside and doing the nitty-gritty AI mathematics, everything was developed in the 50s, 60s, 70s, and 80s. I don't even remember the last time I saw an actual paper that had new mathematics. Everything's just, you know, being able to take what was previously developed and just like you said, do it at scale to actually leverage the power of them.
So I thought it was interesting today that there was an article published saying that Google artificial agents were communicating with each other in encrypted form, and we couldn't understand them. So I would suggest that Skynet is almost here.
So I think this is the real, I think the third rising is the real one, and the reason I believe that is that we've been hardware bound previously, we're no longer hardware bound in any substantial way, and that's the breakthrough. So as you said, the software's been there, the hardware has not, it has arrived. I think that image analytics is going to lead the way by a long shot. I will say that from an operational standpoint, we know so much about how to improve healthcare that we have not implemented yet that has nothing to do with AI, that if we didn't do any AI for 20 years and just implemented the gaps that we already know about, we would have our hands full. So AI has a pretty high bar to reach, except in image analytics, to reach beyond just the existing clinical operational gaps that we have.
Cool.
May, did you want to speak? Oh, okay. So I really like this question. So a question was asked about whether will AI decrease healthcare costs or just add another layer of cost. And it would be great to talk about both in the short term and in the long term.
I think this is a simple question, and the answer is that it will reduce costs because inherently we are talking about replacing humans with machines in some way or another. And definitely human labor is the most costly one.
Go first.
AI, in terms of using data or evidence, outcome data, has been proven to save the industry millions and millions of dollars. Patients who use data have avoided unnecessary surgeries, the wrong medications, gone to the right doctors, had better outcomes. So using data in the digital area definitely will reduce costs and improve quality of care, for sure.
I will disagree. Using AI for precision medicine, where we are able to target the right patients with the right drugs, you know what pharmaceutical companies are going to do. Yeah. They're going to jack up the price. The same thing with the cost of services. If surgeons are going to be performing less surgery, they're going to jack up the price. So I don't think it's going to be automatic. I mean, we have a way of gaming the system so that some people continue to benefit and reaping like the bulk of healthcare costs.
Yeah, I'm hoping that the discussion isn't just about cost. While it might reduce the costs, I think that one of the biggest benefits is going to be freeing the clinician up to really do what the clinician is supposed to do, which is develop that relationship with their patient, the caring, the human touch, and still leverage all the intelligence that they can bring to bear for that patient's condition. That's where the real value is. As we move to value-based reimbursement, I'm not sure it's going to be, whether it's on a fee-for-service basis, whether it reduces costs or raises costs, I don't think is going to be as big an issue. We'll control them no matter what, but it's that human interaction that we'll retrieve, ultimately.
Enrico, do you want to take a question for your side?
Yeah.
Can I make a comment on that? I think that it depends on where the AI is applied. So one of the areas where AI could save some significant cost, if you believe there is some excess imaging, which I think most people believe there is if you applied it to help people choose the appropriate imaging test or the appropriate diagnostic test, you could even generalize it, that has the potential to reduce costs. In the near term, if you provide a tool, let's say an image interpretation help, that has the potential of making a radiologist more productive. If you assume that radiologists have the ability to generate more volume, or the radiology practices generally can increase the volume based on their capacity, which is often true, then you might say that it could increase the cost of care in a fee-for-service environment, because it would allow radiologists to read more studies more quickly. But I think as we move to some of these more advanced payment mechanisms where you're being paid by value rather than by volume, then I think it flips. Okay,
there's a great question here just disappearing at the bottom, which is, what would an alternative healthcare system look like if it was built from the ground up with AI? And the way I read this is a question about the learning health system and how would we implement it. So I wonder if we could just talk about what we think that world looks like. It's not a world of single algorithms, but everything is connected to everything. Anybody want to start off?
So when you can buy 50 terabytes for $50 and you have your own personal cloud of everything about you, including your genome and your microbiome and your phenome, and you are a study of one, so single subject studies, there's a whole methodology emerging around that, and there's going to be more of that. And you can apply machine learning to your subject of one, as in the quantified self. There's going to be a lot more opportunity for self-diagnosis, and I think that's very real. And Vinod Khosla and Andy Groves have been proposing that for many years. I think what you said earlier about allowing healers to become healers again instead of technicians is going to be very important, because the healing power of empathy and the healing power of touch are things that have been lost in the world of technology. And so bringing the ability of the decision process to be much more reproducible and reliable and relevant to an individual will allow the healers. And there was another question about if it frees up physicians, will it also free up nurses? I think we're going to see a big shift in the makeup of the healthcare team. And it's going to shift much more from those with technical skills to those with skills to understand the goals and values of an individual and help individuals make decisions based upon the options surfaced from their personal cloud and the algorithms.
We also have a couple of parents here, so maybe before anyone makes another comment, let's give the parents a chance to, or the patients' families have a chance to say a few words.
Agreed. I see so much hope in this. I know, for instance, if we were building from the ground up, my 4.5-year-old son would have been diagnosed earlier. We were talking about this earlier, that all of the human cultural aspects that go into how my son's symptoms were assessed by the pediatrician before he was able to call for the imaging. Dr. Ohanian, is that Kurt? Is that no? Is that you? Here? Hi, you're an amazing radiologist, and you've read my son's scans many times, and I'm so grateful for you. I just want you to know that. And I see, please, absolutely incredible. And talking about the capacity to free up the physician, the healer, to spend time with us, for us to really come to understand where we are and where our hope is and what treatment really means, to be able to individualize that, which we know in cancer treatment we desperately need in every way. So I feel hopeful hearing all of this today, and I concur that any progress here would be absolutely wonderful. I'm not afraid, and I don't think that our physicians are going anywhere. I think that it's really just opening up the time and space for our connection.
I agree. My name is Mike. My daughter had neuroblastoma, and today at 6:37 a.m. was 5 years. And so this is that she died. So when I hear what the future of hospitals could look like with AI, there are many, many things looking back on our diagnosis that I wish AI was involved with, because early diagnosis took us 4 months to get diagnosed, many doctors. And it took us, I almost had to do something drastic, like punch a pediatrician in the face just to get media coverage to get my child to get a CT scan when an eye is protruding out of the face. So at the time, if I would have had, and I didn't do that, by the way, and I would have never done that, I did it another way, and I got my daughter scanned. If I would have had a phone that could have taken a picture of her face when I first saw that black eye and a little bit of bulging coming out of her eye, and that would have told me, go see, well, obviously as a parent, that would have freaked me out. Neuroblastoma comes up, okay, this is common. Early diagnosis, more patient-centered bedside care, and being able to explain what's really going to happen, proactive versus reactive, is very important to us as parents from another twist. We want you to take a more of a proactive approach versus reactive. There's where you can see some healthcare costs go down. But is it cost monetarily? No. You have to look at the patient's cost, because we have a whole bunch of costs too. So when you drag a patient into the ER at 2 o'clock in the morning, I'm sure you're aware that most people going through cancer, I think over 70%, they go bankrupt. They don't have that kind of money. So if there's a way that we can know proactively that an infection is going to possibly occur, or a reaction to a medication, that's what we need. That's where I want to see the future of hospitals as a parent. Walk in, work with a physician, a care team, because I have to stop saying working with physicians, because we work with care teams, nurses, support staff, everybody. And if there's a way artificially, intelligently, that we can all work together with the computers and say, well, your daughter just had a blood test. We think in 6 months she's going to develop neuroblastoma. We're going to take a proactive approach to this, or maybe not with neuroblastoma, but with ALL or AML or whatever the case may be. Then I think you're going to save more lives. I think you're going to have a better patient experience, and I think that your relationship with your patients are going to be much better. And because they're not going to look at you and think, what do you mean you have no idea? You know, vincristine, my daughter was going to get reaction to vincristine. The doctor said, we just don't know. We're going to keep her here overnight. We're going to pump her full of medication, and she may or may not have a problem. But if she does, more than likely she's going to go on anaphylactic shock and she's going to die. You know, but I want to know if you're going to start pumping medication into my child, are they going to have a reaction? So let's take a proactive approach. That's where I want to see the future of medicine.
I would say that if the medical system were building from the ground up to test a new model where you pay only if you get better. And if you don't get better, you don't pay. And this is like a 30 days money back guarantee or something, right? If this model comes ever, I think it's a platform for AI to work with insurance companies or insurance companies to work with AI to better predict how to price different kinds of services.
I'm just going to add to that in this type of utopia, if you start from the beginning, I think the revolution could happen with a trust network. You talked about blockchain. Blockchain has the potential to unleash data, give it back into the hands of the parents, let them choose if they want to contribute it to science and research and make advances that we just can't do. Anthony has this great analogy of a rocket. AI is like a rocket, and data is the fuel, except the fuel is in 1 million gas tanks all over the world, and we just can't amass it together to put it into the rocket and make it go. AI is useless without data. So how do we get the data out? I think it's much more important than the algorithms. I've heard multiple times people talk about we've got the compute, the software's there, we just need the data.
So I just want to mention one thing before I go on to the next question. So I know a number of you chuckled when he mentioned the 30-day guarantee. So that is actually already happening in many countries, including the United States. A number of employers are out negotiating basically efficacy contracts with pharma and PBMs. And basically they will have to the pharma company will have to pay rebates based on whether their drugs work. And there was a recent case of an oncology medication that is extremely expensive, where they essentially, a pediatric oncology medication, where they basically said, you will pay only if this drug works. So I saw a number of questions talking about how essentially AI will be introduced or how AI will really enter healthcare, and we'll love the thoughts of the experts here about what they think the first several applications of pervasive AI, not just at 1 or 2 institutions, will be in healthcare, and how they think it might really pervade the system.
I think imaging is a good candidate for some early applications. Actually, one of the things that I'm most excited about is quality control. So there are a number of images that we obtain, like mammograms, chest x-rays, and others, where we have human beings who check a certain small quantity of images to make sure that they have the appropriate technical criteria. And that's something that's ripe for application of AI. We have a lot of data about the ratings of images, their quality, and it would not be subject to FDA regulation because it's just part of our operations. It's not direct patient care, and it's something the radiologist is going to review anyhow. So I would say that would be an early one. If I had to choose one that was physician-based, I would say radiologist out of his or her comfort zone.
So I would suggest that the most obvious application of this today is the assemblance of all this disparate information into a coherent presentation that goes off, gets it, finds it, connects the dots, and puts it into an actionable dashboard or some kind of equivalence. You know, to John's point, most of this stuff already exists. If we could just assemble that knowledge and put it into a construct that the patients and the clinicians and the care team can actually use, that for me would be the most compelling and one of the easier, that's maybe not the word I should pick, but more compelling uses for artificial intelligence right out the bat.
And I agree with that, particularly for even in imaging, but as a non-imaging application. I would put that in the category of summarization. So as radiologists, we need that. We see the image. We need a very quick summary of this gigantic chart. And I know everybody else caring for the patient has similar needs. So that would be an incredibly powerful tool.
The question, I think, in some sense boils down to where can AI make the most clearest gains today quickly. I think along the lines that you were speaking of, risk prediction, early warning, that's something where you can clearly say this machine has taken all of these disparate variables and predicted that this person was just about to code or do something else. And I think that's a very clear sell to people that may be a little bit still frightened about what AI means.
So I think it related to the data for AI development. We actually need to treat it in two different levels because big data, AI has been going on forever. However, if you think about whatever the cost for run AI decision in medicine is tremendously different from the other applications like energy, like environment, largely because it's a life and death situation. I think someone already asked a question, what if people die because of the wrong AI decision? So that's the reason why, even for the community, we're working on this community for some time, that we all recognize there are two levels when we're talking about data. Besides the data ownership, privacy, all those issues, there are definitely two levels of it. First level is fundamentally understand whatever the data involved in the data. In that regard, it's more for screening, for wellness, monitoring, that's okay. We actually can develop the AI method for that. But second level, anything related to intervention, it requires an expert. In that regard, I totally agree with Curtis. We have to have the data quality control, annotation, and the trial design. I also think there's someone mentioned earlier on about what if the AI developed in one side, can you move to the other side? That's exactly where we have to, I actually mentioned this in my talk, we have to introduce the regulatory process here because direct experience, we cannot direct move, largely because it's clinical endpoint dependent, it's the data utility dependent, it's actually the experimental design dependent.
So, there is a statistic right now that says that 1 hour of care in the emergency department or the intensive care unit requires 1 hour of documentation. So for basically every hour of you taking care of your patient, you need to go in front of the computer and put data into the electronic medical record. I think that this is a pretty obvious, in my mind, application of AI. Just save this 1 hour and you achieve savings of cost. You achieve improvement of outcome because every hour that your the clinician is away from you is an hour that you can code, rest, and bad things can happen to you. So I think that this is, in my mind, the lowest hanging fruits in
Okay, we have a few minutes left
Could I
now,
just
so,
one thing? Just real quickly.
Very quickly.
Everything we've been talking about is supply side.
Yeah.
We know on the demand side that disorders of lifestyle are driving obesity, diabetes, cancer, dementia, cardiovascular, stroke, everything. And I think AI will play a very important role in personalizing motivational strategies so that we engage the patient. So far, all of our discussion has been about the passive patient. I think we need to think about the activated patient and how AI can personalize and support motivational strategies.
Great, thanks, John. So why don't you hand the mic to May? We'll start with May. Give us, everyone's going to give out a 15 to 30 second tweet about what was the most important thing you learned today. May?
What I learned today is, as a community, we have to work together closely, largely because it's a very big, complex problem. But the hope is not only we can have more patient access, the physician have more time, but also we provide more access of healthcare to more people enabled by AI.
John?
We need more people to attend this conference.
I think there are very disparate contexts within the presentations today. We all work in different environments. What I've learned is that there is a platform of artificial intelligence that goes across all of those areas, and we can leverage that.
Thank you.
I'm grateful for what you all are doing here. Thank you so much as a patient, and I have hope for our future together and for really increasing the care. And I would say that, I don't know, the personalized aspect of this because of this. I don't know if it's artificial intelligence. It seems to be intelligence, but.
I think a sense of urgency. We have a lot of very good ideas, and we spend a lot of time talking about them, and we're all going in different directions. A little coherence and a little urgency. And I still reverberating with the question, it almost sounded like, who was that guy? Bernie, who said, I'm tired of hearing about your emails. I think somebody said, I'm tired of hearing about these comparisons to doctors. And I think that's an answer that we need to think more about. What about these? Where is our gold standard?
Thank you, Randall. Paul?
I found the whole session extremely educational. And I mean, one thing that I've come to notice is that it's not a monolithic thing, AI. And along those lines, I mean, I would suggest it should be, used intelligently. And it can't be all things to all men. It can't solve every problem that was ever discovered in the universe. And I think it's very important to use these, data, and there are a huge amount of data, but that isn't necessarily useful unless you use it properly. It can just be confusing. And there are lots of questions about which there are already a lot of data, but no firm answers.
Okay.
Is coffee good for us or bad for us?
Enrico?
Is chocolate good for us or bad for us?
I would say that even if you're neat on the outside, we're all scruffy on the inside.
Beautiful. Thanks, Giannis.
The collaboration between physicians and technologists, computer science, is very critical. And what I was really pleasantly surprised to see that people talk about the data scientists and the physicians being next to the patient, next to the bed. I think this collaboration is critical.
Thank you. Kevin?
I see there have been a lot of talk about artificial intelligence replacing things, and I think that when you look at the history of tools, that these tools come along and hopefully augment our abilities as opposed to replace them. And I listened to some wonderful talks from obviously fantastic people. I kept getting the feeling, and I hope this isn't true, that the depth, the nuance, and the volume of data is far, far deeper than we might even realize now. I don't know if the rabbit hole ends.
Okay, David?
I would say overall, I think we're in a very good position where we have the software and the hardware required. The two biggest pain points from my perspective are going to be the data, which I think we have a lot of the people here who are actually in a position where they can start to tear down the walls of those silos and start to bring that data together so that we can bring it to bear. And then the other one that I actually haven't seen talked about too much today is going to be UI and UX, the actual interaction with the patient, such that with the patient and the clinician to get the information into the proper hands in the proper form is going to be critical moving forward.
Great. Dr. Nick?
Augmented intelligence is putting the care back into healthcare. #AIMed16.
Truly a tweet. So my insight comes from talking to colleagues in the audience who are doing similar kinds of work and extending the analogy of data being the fuel, sitting in small gasoline cans all over the country. We need to make sure that the nozzle on the fuel can fits into the rocket's gas tank. So we need standards. It's a mundane thing, but I think we really need some standards for how the data for these experiments are organized so they can be repeatable, so they can be compared one to the other, and we can really have the best algorithms rise to the top.
Thank you. Spiro?
There seems to have been a terrific chasm between science and medicine. We keep talking about evidence-based medicine, but the reality is there are millions of articles and databases out there, scientific databases, and clinicians just don't have time or resources to access them. Closing that gap, I think, is probably one of the most important jobs for AI, to allow physicians to have that information at their fingertips. So, and I want to just say, let's go from augmenting to amplifying. I think Rob High mentioned that earlier. We don't talk about AI taking over, we talk about AI amplifying what physicians and healthcare providers can do.
So I've been in a lot of AI-type meetings, and sometimes I'm so deep when working on models that I completely forget about the patients and the caregivers. So I think it's amazing, Anthony, that you invited so many caregivers here. It gives us a very different perspective to some of us who probably spend too much time looking at computer code and not thinking about the patients that we're ultimately working for.
Thanks. I'm going to pass it back here. Todd?
Well, I've learned today that a lot of experts and fascinating people are embracing AI, but based on the questions, I'm also learning that a lot of people are afraid of it. They're afraid what it could do to them, their care of patients, how they treat patients, and patients are afraid what will happen to them. And that basically forces us to do studies in the future proving that AI has a major value. And I've also learned this conference is amazing. You need to do this like much more frequently.
I'm actually going to give a suggestion for a future topic for AI Med. What's the role of AI in addressing social determinants of health? No one talked about social determinants of health, which I could argue has more impact on outcomes rather than the treatments that we're providing.
Can you also tell us what your shirt is made of?
Pineapple.
What?
Pineapple.
Pineapple. All right. That would have been a good trivia question. Okay.
Yeah, well, it just became apparent that while we're absolutely incredibly good at presenting data to caregivers, to patients, we're getting better with patients with portals. We're going to collect data from patients through the portal and through devices. Yet we kind of suck at giving intelligence back to both the caregivers and the patients getting that care. And so I personally have an incredible sense of urgency to begin to change that so that we give more intelligence back than we give data, so that people can really do what they're supposed to do.
I think that we as engineers, or at least I as an engineer, we are conditioned to think that, just build it and they will come. But we forget that adoption in medicine is actually an important component. And I think that we should talk more about how we can drive this adoption, how we can understand the clinical workflow so we can feed technology into it, because this is a really important component. And I think that a lot of technology in healthcare has completely disregarded this. For example, look at the electronic medical record and how many of the physicians in the room like their EMRs.
AI is becoming lately extremely popular. Many companies, many scientists, a lot of capital, a lot of conferences. If there is one goal for AI, is medicine. This is the most important AI conference in the world. Cheers, Anthony.
Wow.
That's fun.
Thank you. I'm very flattered. Thank you.
I think we can work on that at the AI Anthony for president in 2020. Make America healthcare great again.
Yay. Thank you. Thank you.
I got to tell you, you asked what I learned, what we've all learned. I'm not sure what I've learned yet. As a non-physician, but as a parent and a caregiver, I've learned there's a lot of information to absorb. The urgency's here now. The fear's here. It's like the Budweiser truck. There's no way in hell I'd ever get in the back of a Budweiser truck while I was driving down the interstate at 65 miles an hour. That induces a lot of fear in me. But that fear can be good, and what can we use that fear for? We can use that fear to keep progressing in artificial intelligence, to help patients, to help parents, to help caregivers, to help you as physicians, all your care teams, and not only in diagnostics or anything, but it's the emotional part that I've learned that you need. I mean, you've got an hour of time in the ER or in the emergency room, but then you've got an hour of notes to make. What if you didn't have that hour of notes? How much does that hour create stress for you? Now you're trained to do that. But what if you had an extra 45 minutes, and you hit on this earlier, emotionally and mentally? How's that going to help prepare you to help move forward artificial intelligence? I think it all has to be combined.
Well, I'll say that I think, first of all, it's been an amazing day intellectually, emotionally for me. Seeing all of this come together, I'm extremely grateful to everyone in this room, and I think everyone in this room need to get on that rocket. It's going to take all of us embracing what's available to make medicine so great that we don't necessarily need to keep patients in the hospital for an extended period of time in our lifetime. So with that, and I think the best thing is to start mingling with other people that are in other domains to get to know each other. And we have a great reception in front of you waiting, so let the party begin. Thank you very much.